Hello, everyone, and welcome back to Black Mental Health Matters. I'm Dr. Carrie Ann Williams, and this is a talk show that's about everything related to mental wellness in the Black community. So if you have a question or comment throughout the show, just drop a comment. This is streaming live on both Facebook and YouTube. So let us know if you have any thoughts. The topic today is going to be the strong Black woman in therapy. And I am so excited to have with me today Dr. Natalie Court. Welcome to the show.
Thank you. I'm excited to be here.
So, Dr. Natalie Court, a PhD, she's a licensed clinical psychologist. She's an associate professor in the clinical psychology department and the co director of the Center for Multicultural and Global Mental Health at William James College. She also directs the Black Mental Health Graduate Academy, which is a mentoring program to cultivate Black leaders in the psychology and mental health counseling fields. Furthermore, she is the Associate Director of WJC's Specialized Training and Academic Retention Fellowship, and that's funded by the Health Resources and Services Administration. Dr. Court is a research grade psychiatric diagnostician. She has been an investigator, consultant, and clinician on 10 research trials funded by the National Institute of Mental Health, NIMH, and Substance Use and Mental Health Services Administration. Dr. Court grew up in Guyana, South America. She has authored journal articles on racial and ethnic differences in youth mental health, child abuse reporting practices, high-risk sexual behaviors, age-discordant sexual relationships, and depression treatment outcomes. So she is highly qualified to be talking about the topic that we're going to be discussing today, the strong Black woman in therapy. So again, welcome to the show. Just tell us a little bit about yourself. I know I just did a kind of an introduction, but anything else that you want us to know about, why this topic is important to you?
Sure. Yeah, like you said, I grew up in South America, in Guyana, and that, I have to say, has been the most important aspect of my story, I think, as a person of color. I grew up in a space where the first leader of our country after it was decolonized was a Chinese man. We've since had Indian presidents, Black presidents, female presidents. And that matters because I grew up in a space where I saw excellence being demonstrated by everyone, Black, brown, whatever. And that really, I think, shaped how I view myself in terms of my own capacity, my own capabilities, and what I view as possible for myself and other people who look like me. So I think I, like many immigrants to this country, have that story about when you first realize you were Black, and what that actually means. When I first came to this country at the age of 12 and started junior high school and realized that being Black in this country was associated with a whole host of negative adjectives. And I was being told this by Black American peers. And that was really quite astonishing and incredibly sad. So I think that background, being buffered in Guyana from a lot of America's toxic racist history and contemporary experience for many, has allowed me a lot of freedom to fly.
Yeah, and I imagine it contributes to the wide kind of perspective that you may have on what it means to move through the world as a person of color, as a Black woman in various spaces, because you've experienced what it's like to be in a country where the way that you're seen is different from
Mhm.
it is how it is in the U.S.
Yes.
And that's, I think it's very meaningful to have the variety of experiences.
Mhm.
Yeah.
Absolutely.
So, I wanted to kind of launch a little bit into the work that you've been doing and the research that you've been looking into. Tell us a little bit about your most recent kind of research project and the study that you did on Black women in therapy.
Okay. Sorry, we're having some technological difficulties. My most recent research project,
Yes.
correct?
Tell us a little
Okay.
bit about your most recent project and
So
yeah, go ahead.
Sure. So my most recent research project actually involves Guyana. I am, in addition to the other things that I do at WJC, I'm also the faculty director of the Guyana Immersion Program. And so before COVID, um, for a number of years, I had been taking students from William James College to Guyana during the summer for 10 days to conduct suicide gatekeeper prevention trainings. Guyana is a lovely, lovely country, full of so much cultural diversity. But it's also been really impacted by lack or limited mental health infrastructure. And that has contributed to Guyana having one of the highest incidents of suicide in the entire world.
Wow.
And it's usually number three, number two at times, number one at times. So it's really quite distressing. And given how much Guyana has given to me, I wanted to utilize my capabilities as a clinical psychologist and as a professor to give back. And this is one way that I found to be effective. So, what we do there is we recruit individuals who are lay people, doctors, nurses, clerks, police, anybody who's likely to interact with someone who is thinking about suicide, a teacher, etc. And given that there isn't sufficient mental health providers there, we train those individuals to identify signs of suicidal ideation, suicidal thoughts, and we provide them with the skills needed to intervene to reduce suicide. And so, so my latest research is looking at the effectiveness, the preliminary effectiveness and benefit of this intervention that we have developed over the last 4 years or so. So we want to see whether or not there's a change in participants' ability to intervene, in their confidence in intervening if they come across someone who is suicidal. And so I'm really actually pretty excited about that. In that study, we had 44 participants. And I currently am working with a research assistant. His name is Kevin Narine. He's actually from Guyana, from Essequibo. And so he's actually helping me analyze this data currently. So I can't wait to see what we found. So that's the most recent project.
Awesome. And that sounds like really important work. I can't imagine the impact that it will have, once it's completed and you continue on with that.
Mm-hmm. Absolutely. It's
Um,
important.
so let's talk a little bit about what it's like, or what you found about, at least a subsection of Black women
Mm-hmm.
that were able to share some of their thoughts, experiences, feelings about entering into therapy. Tell us a little bit about your that study that you have worked on in the past, and I believe you've already published, or is it pre-published?
Yes. So, and thank you for giving me the opportunity to talk about these amazing women. Um, so, a number of years ago, when I was at the University Rochester Medical Center, my research mentor, Nancy Talbot, conducted a clinical research trial. And in that trial, we were looking at whether or not interpersonal psychotherapy for depression, which is an evidence-based treatment, was more effective than the treatment that one usually receives at most community mental health agencies. So was this evidence-based treatment better than standard treatments in community mental health? And we were specifically interested in women with histories of childhood sexual abuse, and who, as a consequence of the childhood sexual abuse and other traumas, were experiencing major depressive disorder. So that was a 2-year trial. The women participated in about 8 months of psychotherapy. And at the end of that trial, I was responsible for looking at predictors of treatment outcome. So what factors, what variables in this group of women, and these were women, black, white, etc., different racial backgrounds, what factors predicted better treatment outcomes or worse treatment outcomes? And what I found was that if you're a black woman in this clinical trial receiving treatment from licensed clinical mental health providers, you were more likely to have poorer treatment outcomes, meaning the black women in the study did not um, have a significant experience of reduced depression as a consequence of treatment, in comparison to the white women in the study who did get significantly better, whose depression severity did significantly decline. Instead, for the black women, we didn't see a significant change from when they started the study with pretty severe depression to when they ended the study. So being black predicted poor treatment outcome in this depression treatment study, clinical trial. And so that was obviously incredibly concerning. And my colleagues and I really considered what might have gone wrong? Like what did we miss? What were we failing to understand about Black women's treatment experiences that resulted in them not necessarily getting the best treatment experience possible? And so I then embarked on what's called a qualitative research study. And qualitative research studies involve you sitting with participants and asking a series of questions. And it's meant for you to really get at their individual narratives, their individual phenomenological experience. So it's really quite rich research approach. So I met with 21 Black women who had been in the original clinical trial, and I asked them a series of questions to understand what more they needed from us that we hadn't given, right? Again, what did we miss about their life experiences that made it that that left this treatment ineffective in helping them? So that research was really quite fascinating. The stories that they had to tell were heartbreaking, and said a lot about race in this country. Um, so I don't know if I should continue or if you have any questions.
Well, I guess I wonder when you entered into this qualitative study, did you have a kind of a hypothesis of,
Mm.
this kind of thought of, I wonder what these women, what did you expect to hear, or did you kind of go into it and maybe the nature is just, there's no expectations, you just want to know their experiences? I mean, what was kind of your thought going into it?
That's a great question. So with the qualitative method we were using is called consensual qualitative research. That's the approach we were using. And in that approach, you actually have to state your biases. You have to state what your expectations are up front, in order to reduce the likelihood that your bias will impact how you then interpret the results. So I fully expected that the participants, these 21 Black women, would talk a lot about racism. I expected them to talk about multiple experiences of significant racial discrimination, which had then led to or worsened their experience of depression. So that really was the primary expectation that I went into this study with, that racism, racial discrimination, racial marginalization was going to be at the heart of their perception of the causes, the etiology of some of their depressive symptoms. That wasn't actually borne out. So
Wow.
that
But it makes sense because, again, it was a kind of a racial finding to find that a subset of people that are not getting better all what this is what they have in common.
Hmm.
So it kind of makes sense. You think, okay, well, this is probably going to lead in a direction of race, in terms of racism being the cause.
Yes.
So tell us what you actually found.
So, what I actually found was twofold. So there were really wonderful positive results to that study, and then some more poignant, painful results from what they shared. In terms of the positive, these women talked about the fact that they found psychotherapy incredibly useful, right? And obviously, we know that people of color in general tend to underutilize professional mental health services, including psychotherapy. That's been established for decades. We know that. So, having this group of women share that being in therapy was incredibly beneficial for them, they felt that they could be more assertive with their emotional experiences. They felt that they could regulate their emotions better, especially when they felt overwhelmed, when they felt really anxious, really sad. They felt more in control of their ability to regulate those emotions. They felt better because they had a place that was safe and secure and supportive for them to vent, for them to share a lot of troubles and tribulations that they didn't necessarily share elsewhere. So they were able to let go of some of the baggage that they were walking around with. So psychotherapy was very useful for them. They benefited, they enjoyed it, they felt stronger, they felt as though that even though their depression hadn't left them, so to speak, they still felt that they now had really concrete skill sets, really concrete coping methods that they could use to help themselves feel better. They also found that reaching out for support wasn't terrible, like being vulnerable, allowing themselves, these strong Black women, allowing themselves to be vulnerable with others didn't break them. And so that was a powerful knowledge that they received from that experience, that it was okay to be vulnerable, to be open in safe and secure spaces with individuals who were invested in their health and their empowerment. So that those were some of the positive findings.
Wow, I mean that's incredible. I and it's very encouraging. It's very encouraging, to be able to get that feedback that the work that's being done is helpful, it's useful, it's people are they're finding ways to be stronger, they're able to be vulnerable. That's wonderful. Tell me a little bit about some of the other findings.
Yeah, the other findings were very interesting. As a Black woman myself, um, one of the primary findings was that they felt that their life experiences were significantly different than white women's life experiences, and specifically in terms of their exposure to experiences that were depressogenic and traumatic. So they felt that they had more trauma exposure, more exposure to stressors, and therefore were more at risk of experiencing not only experiencing depression but experiencing more severe depression, which makes sense, right? um, and so they felt, as a consequence of their life circumstances being shaped by these exposures to multiple traumas, multiple stressors, limited resources, their experience in psychotherapy also was then impacted by those histories and those experiences. So that they weren't shocked that they had different treatment outcomes than the white women in the study. So that was one, that they were starting off from a different point from white women in terms of the baggage, the burden, the pressures, the responsibilities on their shoulders were significantly more than white women because of the larger history of racism. So, as I said earlier, they didn't talk about having personal experiences of racism and discrimination, but they talked about structural racism, that the system has been set up for centuries in such a way that they are more burdened. And because of their starting therapy with more burdens, the psychotherapy that we were providing to them, which worked well for white women, was insufficient. They needed more from us, and we hadn't recognized that. Um, so that was, I think, for us, one of the most critical understandings. They also talked, race impacted a lot of their therapeutic experience. All of the clinicians in that trial were white. Most were white women. There was one white man in that trial. And it was very interesting because the Black women talked about how supported they felt by their clinicians. They felt held, they felt respected, they felt nurtured, they felt validated, they felt empowered, they felt cared about. They felt that their therapists, their clinicians were nice people, were skilled, were invested in them. But they felt that they did not understand the complexity of their lives as Black women experiencing significant economic marginalization and being subjected to the enmeshed, intractable structural racism. So they did not feel that these white clinicians really had much understanding of factors, these social determinants of health and mental health, that was impacting their depression. And so, on one hand, positive experience, therapy was useful. The therapists themselves were wonderful and supportive, but they didn't fully understand the complexity of these Black women's lives. And as a consequence, obviously, if you aren't able to empathize with someone else, if you aren't able to put yourself in their shoes, so to speak, which is really significant in psychotherapy, then your interventions are less likely to be effective because you're not fully appreciating in a holistic way the multitude of factors that are driving this person's depression and making treatment challenging for them. And so that was one piece that they highlighted that we had not fully considered and had not planned to mitigate. That as a consequence, left them without enough services to get better.
So that contributed to that feeling of the service was nice, it was good, it was helpful, but insufficient,
Mhm.
and insufficient because um, of the in a kind of the lack of ability of their clinician to be able to fully appreciate the extent of the complexity of how they move through the world.
Mm-hmm. Right, right. And I don't know that it's that white clinicians aren't capable, right? It's I think as somebody who has for the last 7, 8 years spent time in a predominantly white academic institution, providing training and teaching predominantly white students, it is possible for white clinicians to develop the necessary empathy to be effective with people of color. What, however, has been missing is the fact that our field has not provided the necessary guidance and expectations around cultural humility that is required for white clinicians, who are the majority of clinicians in our country, to be able to provide fully and truly ethical care to many people of color. So it's not necessarily an indictment of the white clinicians as much as it's an indictment of our field and the leaders in our field not doing enough to integrate issues of multiculturalism into the training of providers. So my colleagues and I at William James College, we recognize that, and that's definitely an area that we're really quite dedicated to addressing.
To talk about, this is a kind of a structural thing, right? That there are so many, white clinicians that are interested and want to understand the complexity and want to learn, want to, they're very kind of invested, but there are others that have not received
Mhm.
that education, they have not received that instruction, and some that have not expressed the interest. Um,
Mhm.
there's just kind of this wide variety of experiences someone can have. So, and then I wanted to kind of go back to this, I guess the idea that some of this is the clients, their perspective
Mhm.
of
Yes.
the clinician. So there's a
Right.
truth. There's a
Mhm.
truth about the lack of understanding, and there's also a perspective
Yes.
or perception of the lack of
Yes.
understanding.
Yes.
And so I want you to maybe talk a little bit about that too. This idea of their perceptions
Yes.
of the clinicians, given that
Mm.
some of their perceptions are true, but some
Mhm.
of it may really just be what they hold.
Right. Absolutely. Great question. That was really quite fascinating. One of the things that we saw from their narratives was a significant degree of idealization of white women, and by extension, their white therapist. So the Black women in the study talked about white women's lives, including their white therapists, being well managed, well organized. They talked about white women having supportive, kind husbands. They talked about them having significant interpersonal supports that are available to them. They talked about white women having more psychological literacy. One woman said, white women have the language of therapy. So, yes, they can do better in therapy because therapy was developed with their language. Um, and so that was quite fascinating because part of that idealization of whiteness also comes at a cost in terms of their perceptions of their blackness and what them as Black women could achieve. Um, and if they were seeing interpersonal supports, solid, caring marriages, a life that's well organized and well balanced as being ascribed really to white women and white people more generally, then what does that mean for them as Black women who will continue to wake up as Black women? Does that mean that they will have and could have access to all of those things they were fantasizing that their clinicians had? So that created some separation, right? If you're sitting across from a person who you're perceiving to have it all, um, and you know that you haven't gotten to that place as yet, then what the women shared was a sense that, again, how could she understand my experience when she has a grandmother who bakes her cookies and a grandmother she can turn to? How could she understand my experience when her troubles are about what college her son is going to get into? Those are not my troubles. My troubles are much more basic. How am I going to protect my kid from being harmed out in the streets? So that was quite fascinating to appreciate for them, that there were these chasms between them and their therapist because of what they were perceiving, because of their biases about their clinicians that weren't necessarily matched to these clinicians' lives, but that was what they were seeing based on America's history, which has defined many things positive with whiteness, which is the definition, right, of white supremacy. People of color internalize those positive white biases too. And they also internalize negative biases about being people of color. Then that has a pretty toxic psychological impact also on our self-esteem, on our sense of self. And again, many of these white clinicians had not been trained, had not been introduced to these factors. So they couldn't necessarily anticipate that the Black women sitting across from them were, yes, benefiting from the connection, but also feeling at times shamed by it. And they could not have anticipated that as a consequence of the internalized white bias, positive white bias that many people of color have, including the Black women in this trial, that would mean that they operated in ways that are problematic in therapy. And what I specifically mean, therapy requires you to disclose. It requires that you share aspects of your life that you don't necessarily share in other spaces, right? It requires that you open up in order for that clinician to most effectively help you. And for these women, what they were sharing was that given their idealized perspective about these white clinicians' lives, they did not want to sully those white clinicians by sharing with them all of their traumas.
Interesting.
The depth of their traumas, the shame of their traumas and their life challenges. So there was a level of protectiveness that was occurring, which was not was to their detriment. And that was shaped, again, by this country's history of race. I mean, what it comes down to is you don't want to make white people uncomfortable. And if I tell this white clinician all of what's happening in my life, they're going to be uncomfortable. And so that's at the most reductive level, what was happening in the therapeutic space. And that's a problem. And white clinicians have to be knowledgeable enough about this country's history of racism, and more specifically, how it psychologically impacted many of us. And the fact that what we've taken in, what we've internalized, shows up in the therapeutic space with white clinicians in particular.
And that's such an interesting and very helpful finding. The idea that what could enter the therapy space and what could kind of get in the way of therapy having the intended or sufficient response could be this idea that now the client feels a slight burden to protect the therapist from the extent of their burden.
Mm-hmm.
They
Mm-hmm.
don't, they, at some level, they feel like the therapist can't hold their
Mm-hmm.
entire burden, that they're really nice people and they
Mm-hmm.
can be vulnerable to a certain point.
Mm-hmm.
But then past that point,
Mm-hmm.
this nice, sweet person cannot hold
Mm-hmm.
the entirety of their experience. And so they can't disclose it.
And that's powerful, and that's such an indictment, right? um, if you're a clinician, this person who is trained in human behavior, who is supposed to be an expert in emotions and trauma and challenge and depression, if you don't feel confident in their ability to stand firm in light of your pain, then that's a huge problem, right? Because for many of these women, many other spaces in their life, they know that to be true, right? They didn't necessarily turn to many other people in their lives because what they shared was that many of the other individuals in their lives were also burdened, were also undergoing significant stressors. So why would I, put my burden on them when I already know they're struggling? So for them to get the courage to come to therapy, because pursuing psychotherapy requires a great deal of courage. It also requires somewhere in the depth of you a level of self-love, right? Because by going to therapy, you're telling yourself inherently that you are valuable enough to have a space that's just about you, right? That you deserve to have someone sit across from you and all of their attention is on you and how you feel. So for these women to jump over a number of obstacles, a number of barriers that exist for people of color to come to therapy and then not fully be able to disclose as much as they could have because the clinicians themselves had not demonstrated the necessary degree of understanding about issues of race and culture is an indictment, and is an area that I feel really passionate about, and I feel that our field has to do better if we want to continue to be relevant. This is a country that by 2050 will be majority minority, right? And for our field to be relevant in the future with racial ethnic minorities, the fastest growing groups of people in this country, then we've got to get our act together. And we can absolutely get our act together.
Oh, and when you do some of the work that you do in terms of like teaching at a predominantly white institution, is some of this kind of material where do you talk to or teach about how white clinicians can bring these issues into the therapy space? Is that kind of part of the curriculum?
Absolutely. It's interesting. As I mentioned before, I was at the University of Rochester Medical Center. I loved it, loved Rochester. And, I had been doing research on racial ethnic disparities in mental health. And at one point, it was just depressing to read about the ways in which our field was failing people of color. And so at a certain point, I recognized that, okay, yes, as a researcher, I can be helpful to this narrative, but I need to be more actively involved in helping to shift this paradigm. And I'm reading about clinicians who are misdiagnosing people of color at epidemic levels, providing care that is not guideline concordant, and they don't even know they're doing it because they're well-meaning, lovely people who want to help, but who have not been challenged about their racial and ethnic internalized biases. And so they're unaware that they are carrying around, like all of us, internal racial biases that are problematic, that impact how they're diagnosing people of color, what they're diagnosing people of color with, and what treatments they're providing to people of color. So instead of me writing about this and researching it, I should be in front of the classroom. I should be in a space where I have an opportunity to change some of these clinicians and diagnosticians' understanding of their responsibility. And so that's a large part of why I changed my career, a large part of why I'm no longer an independent researcher. And so it's been really wonderful to be in a space where I have the capacity to integrate issues of race and culture into all my classes. And just this week, I teach adult psychopathology, and that's a course that I'm passionate about because I am in that course attempting to develop skilled diagnosticians. And so one of the things that I really emphasize to my students is that they have got to examine their racial and ethnic biases regularly.
Yeah.
Because the research is very clear that our biases are one of the primary sources of the disparity in care and disparity in outcome that we see. And that's not inevitable. That can change. And so, they come to learn about psychiatric conditions and how to diagnose them, and they get a class, a number of classes about race. And so last week, actually, I was sharing with my class, my adult psychology class, some of this conversation that we're having today. And I so appreciated the thoughtful questions that my students had, my white students who wanted to know, well, what could I do? What do I need to do to bridge this chasm? How can I present myself in a way that communicates to clients of color that I, as a white person who benefits on a daily basis from a great deal of unearned advantage and privilege, how can I communicate and demonstrate that I get it, right? I might not fully get all of it, but I get it. And how can I express the level of cultural humility necessary for ethical care? So I've loved the work that I've been doing over the last 7-8 years, because I've seen a lot of white students who are going on to be white clinical psychologists shift, grow, learn, welcome more multicultural, less ethnocentric perspectives about psychopathology and about ways in which we can help everyone.
Wow. And I imagine that the answer isn't simple. Like, it's not just kind of like, do this one thing and you'll be fine with all your Black patients or your Black clients. It sounds from your answer that it requires some amount of introspection and reflecting on your biases. And then, some of it is going to be just further clinical training itself about how to bring these topics up, what to talk about, how to say this, it's not really just kind of like one thing. It does require additional education and study and reading and learning.
Absolutely.
Yeah.
Absolutely. And that starts with cultural humility, which really means that you recognize that learning about yourself as a cultural being is a lifelong endeavor. And therefore, learning about other people as cultural beings also requires continual engagement. You have to employ your curiosity. You have to ask questions. You have to challenge your biases and your hypotheses that you have and your stereotypes. So being culturally humble inherently means that you have to put away arrogance and pomposity, right? And you can't be defensive, right? So for the white clinicians that I train, I need you to absolutely embrace the truth of this country's history, right? If you're wincing or feeling defensive about 400 years of oppression and marginalization, then we have a problem, because that is the country's history. This country has been more defined by apartheid than civil rights, right? So you need to, at baseline, recognize and appreciate the facts, right? And not be defensive about them. So that's the start. Understand the history, and therefore understand how that history is fully engaged in our contemporary world, and how more specifically it's impacting us as mental health providers. So that comes from science, right? And science and research that's demonstrated these disparities and the sources of these disparities. Then one has to commit to continually asking themselves questions about their racial bias, not beating yourself up about it, because our biases are not voluntary. They're not chosen, or implicit biases, I should say. It's a reflection of our world. So if your world is presenting to you misogynistic perspectives, homophobic perspectives, transphobic perspectives, Islamophobic perspectives, racist, anti-Asian, anti-Black perspectives, etc., then that's internalized. Our responsibility is to know that fact and then push against it, push against it, push against it. So that includes exposing yourself to a different narrative than the stereotype. Don't feed the stereotype. Go looking for narratives that are more honest and more truthful about people, about everyone. And so those are some points that I make to my students. But additionally, as clinical psychologists, if there are clinical psychologists out there listening, if you are a diagnostician, then you have to be engaging in best practice. And because we know the more we engage in empirically supported practices, the less our implicit racial biases have an impact on our diagnostic decisions. So, what I mean is that if you're a diagnostician, you need to be trained in a semi structured or structured diagnostic evaluation process that you're using with every client, where you're asking questions about every domain of psychopathology. So we see that when people employ those structured or semi-structured evaluative tools, their biases have less ability to impede their accurate diagnostic decisions. It's not enough, but it's one way to help to reduce the impact of bias diagnostically. So that's part of what I'm training my students as diagnosticians to go to the science. So those are a couple of ways that I encourage them to move forward in being better clinicians.
That's very well said. So I hope that folks listening out there, and I would even say clinicians of varying backgrounds, not even just white clinicians too. I know that's been our kind of our talk today, but I thought about myself moving to the U.S. and I've had to read on my own too.
Mhm.
I've had to think about what are the messages that I learned about Americans. What
Mhm.
did I learn about white Americans? What did I learn about Black Americans?
Mhm.
What were the messages that were taught to me by TV?
Mhm.
Um, and I've had to do that reading and that um, kind of spending time with people, learning about their lives, kind of rewriting the narratives that the media has fed me about who people are. And so for all of us, it's like this ongoing journey of
Mhm.
examining what were we taught, what did we internalize,
Mhm.
um, and what do we need to work on. And so I hope that everyone that's listening today can get some benefit out of this discussion, to think about how, if you're a client or a therapist, or just someone listening in, that you can still benefit from this. And so, any last thoughts, Dr. Court?
So, um, I really appreciate the fact that you're doing this work. So thank you for giving such an amazing space, and in a space that many scholars in the Black Mental Health Graduate Academy have had an opportunity to take part in. It's important for us to have um, our voice out there. Representation absolutely matters. I can't stress that enough. So you're absolutely right that we all internalize many of the same negative perspectives about people of color, and we people of color internalize those perspectives
Yeah.
too, right? um, the melanin, my lovely brown skin, is not enough to make me a culturally competent or culturally humble clinician. It isn't. And like you said, I have to do my own work. I have to challenge my own biases. I have to be really attuned to the messages that have been internalized and be really careful. So you're absolutely right that we all have to engage in this. It's more, emphasize white clinicians because they're the majority and they'll continue to be the majority providers for some time. And because we know that this can change, we know that this can be improved. So I share with my students that they must continue to examine their implicit racial biases as regularly as possible. I love this field. It's a brilliant field. Um, it's a blessed field. When you're sitting across from someone who is in pain, who's confused, who's unsure, who is fearful and anxious, and you have the gift and the blessing to create a safe space where they feel seen, feel visible, feel held, feel respected. That's an amazing thing. So, we think a lot when we think about this field about pain, and it is oftentimes about pain and hardship. But for me, I think it's much more defined by hope, by connection, by love, by strength, by courage. And so I hope that, if there are some young people listening today, consider this field, consider showing up in this field, and especially people of color. We need more people of color in the mental health field for the reasons that I've shared earlier. So, as you know, at William James College, we've put our money where our mouth is, so to speak, and have engaged over the last 5 to 6 years in creating programs to invite students from historically underrepresented communities to come to WJC to become leaders and experts in psychology and mental health counseling. So I want you guys to check out the Center for Multicultural and Global Mental Health. We are proud of the fact that we have programs like an Asian mental health program, African and Caribbean mental health program, Latino mental health program, a program that focuses on immigrants and refugees, programs that you're not going to find in many other graduate schools. And that's a shame. That's a shame. And hopefully we see changes happen in those spaces in the next 5 years. But we also have the Black Mental Health Graduate Academy, which I have the pleasure of directing. And I'm so proud right now. I'm beaming with pride because we recently graduated 14
14.
14 Black psychologists and mental health counselors. And given the fact that I was the only Black person I knew in graduate school, it is a
That's
wondrous,
a large number.
it's a wondrous thing to see these talented, amazing future leaders of psychology and mental health counseling. So we want to continue that. We want to continue supporting and providing the sociocultural secure base that we need in predominantly white academic institutions, because representation matters. The changes that are required in our field requires, yes, white clinicians to do better around understanding issues of race and culture, but it also requires for us to be in those spaces, for us to be in those classrooms, for us to be in those community mental health agencies, because with our presence comes our experiences, comes our questions that might not be asked, might not be seen as relevant, or might not even be understood. So it is our responsibility to encourage as many young people as possible who have a gift for providing a safe space to consider this field. You are needed. You're absolutely needed.
I agree. I agree. So thanks for those of you guys that have been, who joined us for our show today, have been listening. Said drop a comment if you appreciated the discussion, and if you are listening and you're passionate about Black mental health and you would love to kind of join the discussion, or if you're a mental health provider and you want to be a guest on the show, just drop me a comment or check in with me. And tune in again next Sunday at 1 p.m., where we'll have our live stream of this show on YouTube and on Facebook. So take care. Bye.
Thank you, Dr. Williams. Appreciate it.